testing. Which one? Which one? Which one? Tertius. Good. You're everting, so you're still going to get some of them, but remember the other two peroneals are plantar flexors. Oh, no. But what if you don't have a tertius? You're going to get compensatory motions. You could do extensor, digitorum longus has some of that motions too. You could always do gross. You don't have to pick all the muscles. Go straight up. That's your extensor compartment. You can go into straight eversion, so put your foot out. You could do some inversion, but these are not specific muscles. Remember that. Go on your left side facing me. Good. I want you to point your foot diagonally up like this towards the ceiling. Good, but down a little bit. Yep, good. What is that test for? Post tib. Go on your right side. And now we're going into down and up towards the ceiling. Good. What's that? Peroneus longus and brevis. And then I guess technically you have two different ways of doing the calves, so go on your stomach. So you could do this, toes towards the ceiling. Soleus. Do that, toes towards the ceiling. Gastroc, and what's the other way of doing those in a more functional position?
Heel raises.
What's a 5 out of 5?
20-25.
So you gotta think, heel height's important, but really what if somebody can't do it? If he's 80 years old and he can't do any one-legged calf raises, certainly you have to try something else. Maybe they're in pain and, I can't do any, that hurts, ow. Okay, well I want to know that if I could put at least my muscle force through it, does it at least evoke pain? Or is there a strength issue? Or maybe it doesn't hurt, but he's still shaking and weak. Those are all things you have to take into consideration. Yes, this is the stronger way, but there's other ways of doing it too. All right, that was that. Extensor hallucis you could do too. That's in sitting where it's just the big toe. Come on down. Lift those big toes up. No, not those, put those down. Oh, geez, you did. Oh, I was just kidding. Good for you.
How do you do that, EJ?
Don't even get me started on this whole toe thing. Don't even get me started.
So that's your strength. So you get to that, none of your external stabilization stuff helped, or some of your foot mobilizations you had to work on during your functional testing, or you noticed something during your screens. You get to a strength breakout, that's your inner range strength, picking out a particular muscle. And then that's how we got to this point. The main ones probably to think, certainly you can have problems anywhere, but posterior tib is a huge one, gastroc is a huge one, and you do have to be aware of any of your dorsiflexors and your hallux extension, not for solely this muscle strained, but they are commonly the ones affected when we get to lumbar injuries. So dorsiflexion weakness, eversion weakness, that's L5, and that's a very common area for injury, so be aware of that. But when it comes to actual local weakness, either S1 problems at the back or just isolated calf and posterior tib injuries will affect your strength too. So local, global level, good. This is just a repeat from before. Motor control, posture, aerodynamic, soft tissue, wonderful. Assessment, there's really no change here. This is the same stuff you guys do for documentation.
Can we talk about Morton's neuroma really quick?
Sure.
I just have a question. I know it deals with the third and fourth. I know we didn't have a question on it today, but what is the cause of Morton's neuroma?
I want to say compression.
Yeah, it's nerve, right?
Well, the nerve is the source of the pain, but it's what's occurring at the nerve, how it got inflamed or irritated. Usually it's compression in nature.
It's only usually the third and fourth toes.
That's the most common area you see it along where the metatarsal heads are.
Okay.
I think it's allowed to be in a different area, but that's where it's most commonly seen.
Okay.
Why do you get? Is it the daylight sign? I think it's called. I don't.
Between
There's
your
called
toes?
something, yeah, because their toes like spread out.
How's that daylight?
Like, it
I don't
seems
know.
illegal.
I'm probably calling it wrong, but why do their toes spread out when they have
You
that?
can get splaying.
Yeah.
So that's a lack of support inside to keep you together.
Uh,
That's where you get splaying, and that would
Okay.
cause shearing. That would also cause increased compression directly to that spot because you're not getting the support needed.
okay.
All good? All right, so we got that. Goals, guys, same thing. So PA diagnoses, we talked a little bit about this, and we'll do our little not in-service, what do you call them in class? Webinars. Posterior tib dysfunction, we already talked about, it's a movement problem, but if the posterior tib develops some sort of tendinosis or tendinopathy, that's something to be aware of. Medial lateral ankle sprains we discussed. Jones fracture is just the fracture of the base of the fifth, or the metatarsal head, and that's, not the metatarsal, the base of the fifth, and that's not good because of malunion rates. Metatarsalgia, it's just pathology of the metatarsals, so AKA pain along the forefoot, and midfoot, you gotta figure that out. Morton's neuroma we just discussed is that nerve irritation along the, what do you call them, the plantar nerves. Shin splints, if it's along the anterolateral aspect, that's usually coming from a lot of ground reaction forces, but certainly it could be from the grabbing of your anterior tib, where if you have posterior shin splints, this is the posteromedial aspect of your tibia. That's your posterior tibial stress syndrome. And that's more of your posterior musculature as well as ground reaction forces. Fractures is usually just from falls. Total ankles, not much to know. The main takeaway for a total ankle is that your focus is on stability, not on mobility. And it's still new, and they're not a commonly done surgery, but they found that the more you try to improve mobility, the more unstable it becomes and fails. So stability is their your main goal. And same with joint fusions. You could see isolated talocrural fusions, isolated subtalar fusions, and you just want to be aware of if joint X is fused to joint Y, what am I going to be missing? That's it for that. So mechanical diagnoses, we talked about this when it came to the column 2, where this was laid out. Basically, you can have corrections at the arch, at the talus, at the tib fib. Of course, the one we didn't teach you is you could also do it at the calcaneus medially for Sam. You could do stability, that's the stack at the arch, the stack at the tib fib. And then you could do motor control, which there's different things. I know Dr. Ard taught you guys tripod. I like to do taking the metatarsal backwards, and this creates a cupping motion. Some people like to do, let's see, is this technically internal cueing, where you just put a penny underneath here and say lift your foot up off the penny?
External.
Oh, that's external? Oh, man.
Yeah.
That's fine. I
I
make mistakes, guys.
First one where he's like,
90% of the time.
Yeah.
Yeah.
Make mistakes.
That's a metaphor.
I'm just thinking of different ways.
Now do you want to
Got, self-confidence, right?
Yeah,
Good.
We should know that. Scary.
All right, so we're good on those. So you just have to find where the issue's coming from. Is it a local or global issue? Followed by where is the movement pattern coming from? So that's your driver assessment in column 2. You fix something, it makes it better. That's where the problem's coming from. And then the reason, is it weakness, stabilization, motor control issue? We use this, I like this one as a common driver. So I use dynamic valgus because basically you can look at the pelvis, the hip, the knee, the ankle, the foot, all in one common thing. It's a common motion. And you guys answered this for me. We talked about how your ankle can move too much because of your hip being a problem, but you could also have your ankle moving too much causing a problem at your hip. So it's a two-way street. So I like that as an example because you can have almost all of your lower extremity injuries come from this movement pattern. It's just a matter of which joint is the dysfunction at. That is where you need to figure it out. And then our interventions are based off of this. And that's that. So ankle interventions, there's nothing that's a repeat slides. Great, great, great. So when we are going through this, we can repeat when we break up for practice, we can repeat the posterior glide. You already saw the different positions to do it in. You can repeat the anterior glide. You can repeat this, repeat that. Good. First ray. When it comes to a thrust technique, just long sit for me. So, when you're doing your first ray mobilization, you find the appropriate spot. Great. Dr. R already taught you the thrust for the cuboid. This is the same thing when it comes to the first ray. Once you find your spot and you support it, you just need to make sure that you're locking up the other joints, because all the thrust is, if you put your hand on something, put slack until it's not moving anymore, and you can see I'm not pushing as hard as I can. I'm just picking up slack like I would with a grade 4, and then once I'm at that end range, all I'm doing is a quick thrust at the end. That's a grade 5. Most common mistakes is people are tugging, they gotta go past it, they always go past the end range barrier. When I thrust, I move his whole leg. That's bad too, because it's a big motion. All it is my grade 4, and then a quick thrust at the end, and then that's it. So when you do this, all you're gonna do is check on the symptoms. So make sure that there's no pain, you feel your barrier and your end range. You notice too that you would want to hold the position. So Dr. Rodriguez, same thing for the cuboid. He held the position, made sure it was comfortable. He asked Nick about pain. Do you have any pain, EJ? Good. And then he asked Nick, oh, what I'm gonna do is a quick little thrust. And when he did that, he backed off and he showed him what a quick little thrust was like. So what I'm gonna do is I'm gonna back off, and all I'm gonna do is at that end range, I'm gonna apply a quick thrust like this. Is that okay? Good. And then you may or may not get a cavitation. Some of you found that you got one when you did the cuboid. Other people found that you did not when you did the cuboid, and that doesn't mean you did it incorrectly. So all you want to check is a pre and post test. Some people may need it, some people may not. What would be my pre-test for this one?
Grade 4.
Nope. So he already has pretty good extension. So you, other than pain and range, you can see how it feels. And then when you do your mobilization, you just want to do a retest at the end. I think, Dr. Rodriguez, I heard you said you will go directly onto the bone? For the moat?
Oh, yeah, depending on hand, foot differential. If I can't get a good grab on the first ray with my fingers, the ideal is grabbing the first ray, having a thumb there, hand goes over the thumb. But sometimes the first ray isn't long enough for me to get that, so I'll sacrifice the thumb contact so I can get a good first ray contact, and then I'll go either thenar or hypothenar directly on the base of the first mat. So instead of going through the thumb, my hypothenar or thenar will be directly on the mat.
So then at the end range, when we get where Kirk can say, quick thrust, and that's it. Then you retest.
And you would do that if they were really had a, at that point, why would you do a thrust over like a
You
grade
feel like
4?
something's stuck and you just
Okay.
need to get it unstuck.
What's functionally how much range do you need out of the first stop?
60,
Extension? 60?
60 to 80 is your norm. So you're good. He has norm. So that's what you would do for that, but the concept stays the same. Doesn't matter if you're doing it on the neck, the lumbar spine, the foot, hip, the concept's all the same. So that you've already done your grade 1 through 4s. All you have to do now is practice talking to the individual, getting informed consent, holding for the end range to make sure it's pain-free. That's your pre-manipulative hold. And then your quick thrust at the end, and that just takes practice. So that's that. MTP we did. Distal fib we did. Oh, for grade 5. For the rear foot thrust. Can I borrow that? I need to put my back in front of it, sorry.